I'm Olaf Riess. I'm the director of the Institute of Medical Genetics and Applied Genomics in a beautiful town in southwest Germany called Tübingen, and we have mostly clinical applications of genomics. To understand the German way of approaching genomics into the clinics or in general population, you have to understand that we are part of the European Commission. So that means most of our research programs are done combined with other countries, so in a concerted action, and are announced by the European Commission. And then we have the national programs which are more directed into clinical applications. So we have different levels of starting. So one is that I was leading a European program, research program on rare diseases, what we call Solving the Unsolved, or Solve-RD, which was running for the last 5 years, and which was targeting in particularly to these patients who had an exome sequenced, and we reanalyzed all the data, made functional genomics and new sequencing technologies to really find out what is the cause of the missing genetic mutations. The other one, the clinical application, just started 2 months ago. The key finding is that first of all, genomics is important for rare diseases, for cancer, but we move into common diseases now as well. It's not only important to have a diagnosis, but also for the patient to communicate, to see, how a disease evolves and develops and so on. So basically, genomics has reached the clinic area. So the point is, if the costs wouldn't have gone down so dramatic, nobody anticipated, we would not talk about this today, because we could not afford as a country to do large-scale sequencing effort, and we could definitely not afford at all to bring it into the clinic. Second part is really technology availability. So we are very quick now. So within a few days, we provide the diagnosis to the patient. So cost and time is an issue as well to bring it into clinic. I strongly believe that technology drives the clinical application. And as you sort of mentioned, the long-read sequencing a bit, so my belief is that in case for the rare diseases, we are moving heavily into the long reads. You can do the epigenome, at least for a part, with the long reads, and we have imprinting diseases which are based on methylation failure in rare diseases. You can do the very long stretches with the long read sequencing. So the point is that even with the long read sequences, we have a new or we generate a new reference genome, what we call telomere to telomere or T2T sequencing. And at least our institute is already moving and bringing long read sequencing into the clinic. So I believe for the rare diseases, for most of them, not all of them, but most of them, we move to the long read sequencing. But in the common diseases, in cancer applications and so on, and treatment follow-up, like with cell-free DNA testing and all this, it will always be the short read, because you do sequencing very deep into the genome. And so it's a different type of applications. So both are necessary. We are using it since many years already. We have the G400 machine in our lab since 7 years or longer. It works really very reliable, very nice, and good sequencing, very few errors, and we have it for specialized applications. Yes, we are exploring the different collaboration MGI, for the future, and how we will, integrate the technology. We are deeply impressed about the developments of MGI technology. We are deeply impressed on that you think the technology from bottom up and not from top down. So you look into what the customer is needing, and that's basically what you provide, and not just as a single equipment, but looking from the start, from the DNA isolation to the end, to the data analysis. I believe if we use genomics in the right way, as interactions, that the people do understand why there is a need, we can prevent diseases. So we could use this information to either detect diseases at very early stages and then easily cured, or even to prevent diseases. And that is the great chance of genomics.